This is exciting, isn't it? You are in the presence of one of the great minds in the world on heart cardiovascular research. Dr. Böger studied medicine at Hanover Medical School. He was a doctoral student at the Department of Anatomy at the Hanover Medical School in Hanover, Germany. Postdoctorate fellow at the Institute of Clinical Pharmacology, at the Clinic for Angiology at the Hanover Medical School, at the Falk Cardiovascular Research Center, Stanford University School of Medicine, board certified in clinical pharmacology, senior research fellow at the Institute of Clinical Pharmacology, board certification in pharmacology and toxicology, professor for clinical pharmacology, head clinical pharmacological unit, Institute of Experiment and Clinical Pharmacology and Toxicology at the University Medical Center in Hamburg, current head of the Hospital Drug Committee of University Medical Center, Hamburg, current member of the Ethics Committee of the Hamburg Board of Physicians since 2002, its deputy president since 2006, medical director of the Clinical Trial Center north of the University Medical Center at Hamburg, director of the Institute of Clinical Pharmacology and Toxicology at the University Medical Center in Hamburg, author of more than 140 original research papers in peer-reviewed journals, over 60 papers on studies relating to ADMA, arginine supplementation, 50 review articles, 60 book chapters and other publications, and the organizer and director of the International Symposium on ADMA. How lucky are we to hear from Dr. Rainer Böger from Hamburg, Germany.
Thank you, John, for this kind introduction. You're giving me a hard time meeting all these expectations that you made rise so high. I hope I can compete with that. It's a great pleasure for me to be here, to be back in the west of the US, where I have spent one of the luckier phases of my life in 1996 in Dr. John Cook's lab at Stanford, where I learned a lot, where I was involved in a couple of studies that I'm going to show you the data of here today. But we've moved that on since then and learned a lot ourselves. And as I said a couple of times today, it wouldn't help me much being a scientist sitting in my lab doing some research and thinking about my own data and not sharing it with anybody. I'm a medical doctor. I'm not treating patients personally, but I can understand as my task to help you treat patients more effectively and prevent disease. And that is my dedication. And that's how I got involved with Arginin and finally with ADMA, a little story that I'm going to tell you all today. That is basically what my presentation is about. Let us start with this poor guy who has been in the restaurant in the winter in the weather like we have here today in Spokane. Snow on the outside, it's cold, it's chilly, it was warm inside. He had a heavy meal, some fat and other good stuff to eat. And he obviously is in ill shape, as you can see. So what is considered to be a cross-section through a coronary artery to the right of this presentation obviously is not his coronary artery. His coronary artery has stenosis, atherosclerosis. And probably in this acute situation he is in, not even what you see now is his coronary artery. What his coronary artery is about, it's all closed. He has thromboembolic disease in the coronary artery. He is about to suffer myocardial infarction. And even today, although we have high-tech medicine, high-tech cardiology, all this catheter intervention, stents, cabbage surgery, and so on, many people in acute myocardial infarction will die of it. And if not the first myocardial infarction, then maybe of the second. So when I was a young doctor in 1990, I remember exactly. I got involved with cardiovascular disease, and I thought to myself, do I want to be a cardiologist and treat all these poor souls at a stage when it's basically much too late? What would I want for myself? I would love to avoid the cath lab as long as I can, unless I'm a cardiologist and standing on the right side of the needle, of course. But as a patient, I wouldn't want to ever have to enter the cath lab. Don't know whether that will fulfill itself, but I'm doing what I can. So I thought, if I'm about to do something on cardiovascular disease, my dedication must be prevention and not treatment of the disease. I'm a pharmacologist. I'm involved with research on drugs, understanding how drugs work, how long they reside in the body, how they are metabolized and excreted, what their mechanism of action is, all this stuff. But even with drugs, many people are treated much too late. No insurance company will pay for a drug for someone who has no indication, and indication is the overt disease. Again, that's too late to prevent the disease. So prevention is all about. Like this poor soul here that didn't listen to prevention. The scientific part of it is, if we want to do prevention, we have to understand the disease. We have to understand the molecular mechanisms that are going on in our body that drive the disease, and understand what are the early changes in someone aged 20 or 30 when the disease process that will end up with myocardial infarction at the age of 60 or 70 is initiated. How can we detect someone who is on that track and discriminate him from another person who is not on that track? Clinical medicine cannot do that currently. There are now no tests out there that the primary physician will do, that any insurance company will pay for. It's not imprinted in the skin. You have the disease, you don't, or something like that. So obviously, it's good for me. There's a lot of science to be done about that, and I will not lose my job. But anyway, we have moved along in the last 20 years, and we've learned a lot, and I will share some of these data that we have learned from our studies and from studies of other groups to understand that. First thing, in the early 1990s, there was a hype on nitric oxide. Nitric oxide had just been discovered as a molecule. Everybody understood that in the vascular system, nitric oxide is a very important molecule. And we had just heard of the discovery that this nitric oxide, which is so important, is being formed by the body from L-arginine. And what I show to you here is one of my very first studies I've ever done as a young physician. We took a group of rabbits. Rabbits eat plants, so they never take in cholesterol. When you feed a poor rabbit in a cage who can't avoid it with cholesterol, that rabbit will become sick in a couple of weeks. So in a rabbit, giving a rabbit cholesterol can mimic the disease that in humans takes 20, 30, 40 years within a couple of weeks, which was wonderful for me as a young and impatient doctor, because I could get my results quite quickly and not wait until I'm an old man. So we took a group of poor rabbits, put them in the cage, and fed them with a diet that contained lots of cholesterol. Their cholesterol level rose to something like 600 or 800, so really high. And we kept them on that diet for 3 months. As I said, what we understood from the biochemistry behind it, why is this vessel diseased, was that nitric oxide was reduced. Nitric oxide, which is formed from L-arginine. And we then had the thought, we might try and treat these animals with arginine and see what happens. if there's lack of NO formed from arginine, maybe we can improve it if we just give arginine to the animals. We did that, and you see on this graph, two arteries again. The upper one is from a cholesterol-fed rabbit, and you see it looks like the other one I showed to you before, lots of atherosclerosis. The lower one is also from a rabbit-fed cholesterol, but a rabbit that, in addition to cholesterol got L-arginine in drinking water. And as you can see, there is no atherosclerosis in this animal. It's amazing. We were really, we couldn't believe it. So what we did, we couldn't believe it. What we did, we did a second experiment. We repeated that all because we thought we had done something wrong. And we found the same again. And then I read a paper from Professor John Cook from Stanford. He had done a similar experiment, and he had found the same thing also. So there must be some truth in it. Here is the quantification for those who are used to see these scientific slides. This is with some statistics. What you see on the left side is the carotid artery, which is the artery that brings blood to the brain. You see on the very left, the bar that you almost can't see is from the control group, meaning healthy rabbits don't have atherosclerosis. You wouldn't expect them to have it, but this is the proof. The second one is cholesterol-treated group, the black one, and you see it's about 40 to 45% of the carotid artery is covered by atherosclerosis. The third one is a group of rabbits treated similarly with cholesterol plus L-arginine in that case, and the atherosclerosis is reduced to only 10%, which is more than 80% reduction that we see in the disease. Incredibly strong. We haven't seen that with any drug, but we've seen it with a natural component of the diet, with arginine. Incredible. And the last one, the red one, is a group of rabbits that were treated with a substance with L name, which is a chemical substance that blocks NO formation. So we thought we could even make the disease worse, but that didn't happen. Cholesterol alone eraded NO formation, and any chemical inhibitor, potent chemical inhibitor of NO formation like L-name, couldn't make anything worse than it was. So on the right side, you see the same was true for the thoracic aorta. Significant reduction of the amount of atherosclerosis by L-arginine. This biochemistry of the NO synthase is something that biochemists had done in a reagent tube in the lab, in vitro. And what we analyzed was in the living organism, in the rabbit, in humans, by the way. I'll show you some of the human data we have. So there may be a difference between a test tube and such a nice guy from Bavaria in the south of Germany. Although some people from northern Germany would argue against that, because this is someone from South Germany. Again, this graph at the bottom shows to you what's going on there. It shows you that with increasing L-arginine along this x-axis, the activity of the NO synthase is increased to a level where it reaches a ceiling and cannot be increased anymore. The normal L-arginine level, let me see where my cursor is. The normal L-arginine level is in the range of 80 to 120 micromoles. So it should be in the range where when you increase it, nothing more can happen. But it does. The only reason why this could happen that we could think of was that potentially there's an endogenous competitive inhibitor present that makes this whole curve shift to the right and bring us to a situation where within this normal range of L-arginine there is a modification of enzyme activity. And that's what we set out to test at that stage, mid of the 1990s. But before I show you what we found then, I want to discuss with you a little bit about the question, why is atherosclerosis so common in our population? 50% of our population in Germany, 50% of the American population will die of heart disease, of heart attack and stroke. So every second person in the room, and you can count 1, 2, 1, 2, who will die and who won't by heart attack. Make sure that you start with yourself, because every second will die of heart attack. The answer why this happens is our Western lifestyle. And if you look at it from an evolutionary perspective, like this slide, which I borrowed from a colleague of mine from the University of Münster, Georg Assmann, he nicely depicted it. It is something inherent to the development of humankind until the year 2010. I apologize for not having a female version of this. So again, why? If it weren't for the fact that the TV set and the refrigerator are so far apart, some of us wouldn't get any exercise at all. But what overweight, high cholesterol, high blood pressure, lack of exercise, smoking, diabetes, all these conditions do on our body basically can be summarized as an increase of oxygen-derived free radicals. Radicals can be derived from normal molecules by chemical reaction, and the benignant molecule can be changed into a free radical by UV rays, by cigarette smoke content, by the presence of any risk factors. High cholesterol is oxidized to oxidized cholesterol, and that's what really hurts the cardiovascular system. So the body is attacked by free radicals, and the body has mechanisms to prevent these radicals from harming the body. Radicals, when they attack another molecule, induce a chain reaction, because of that other molecule that is being attacked by a radical itself is turned into a radical and will attack another molecule, and so on. It's a chain reaction which results in a lot of tissue damage at the end. The body has its own antioxidant defense mechanisms against this. And one of them is nitric oxide. I've seen lots of studies in which people gave vitamin C, vitamin E in controlled, placebo-controlled, randomized prospective studies, and it all didn't work out. And the medical community was astonished. Why didn't it work? Well, I think because one single antioxidant like vitamin C, one single antioxidant like vitamin E cannot do it on its own. What we have to do is take the body and take the body's own protective mechanisms and reactivate them, because the body knows where this antioxidant system must be, in which cells, in which part of the cell. We need to reactivate what the body itself has and not give some pharmaceutical substances there. Okay, that's why I became so fond of nitric oxide. When you think of nitric oxide, you've heard of it. Many of you have heard of nitric oxide as a pollutant. Every car produces nitric oxide, and no one wants the car to produce nitric oxide, because there's lots of nitric oxide coming out of the car. It's an environmental pollutant. It's a toxic. But the body itself can do exactly the same. The body, the artery, can produce nitric oxide. It does it at well-controlled, low rates. And this nitric oxide is an endogenous defense mechanism of the artery against everything that can harm it. We have known it for 25 years now. Louis Ignarro, Robert Furchgott, and Farid Murad got the Nobel Prize of Medicine way back for this discovery of nitric oxide because it was way-breaking and enhanced our understanding of cardiovascular health. This nitric oxide keeps the arteries flexible. It induces vasodilatation. It prevents blood platelets from getting sticky, causing thrombosis and embolism. So it inhibits platelet aggregation. It's, if you want, take it as the body's endogenous aspirin. It inhibits inflammatory cells, leukocytes, monocytes, from adhering to the vessel wall, invading the vessel wall and causing inflammation in the vessel wall, which ultimately leads to the atherosclerotic plaque. It inhibits smooth muscle cells from proliferating. One of the major problems that we have after stenting. Stenting is fine, but the area where the stent is closes again because there's cell proliferation going on. Nitric oxide prevents this, but the people who get the stent don't have nitric oxide anymore. And nitric oxide is an endogenous antioxidant. It acts against superoxide radicals, it acts against LDL oxidation, and prevents all the harmful mechanisms that are induced by these free radicals. I've told you about that a little earlier. Our understanding was that there is an enzyme in the vascular wall called nitric oxide synthase that makes NO from L-arginine. And this NO then will do all the good things I showed to you. As an example, I picked vasodilatation here. It doesn't work in everybody. And I'll show you how you can visualize that. See this radiograph, which is a contrast angiography taken from the main abdominal aorta. You see the kidneys there, and at the bottom you see how the aorta splits into the two femoral arteries that go into the right and left leg, bringing the blood to the lower extremities. This is another angiograph. There's a bit of difference between it. Every layperson can see there is a difference in there. And I must not ask which artery system you would want to have. I'm also not asking which one you do have. The difference between the two is 50 years of Western lifestyle. Putting it in other words, and that's part of the fascination that I have with the cardiovascular system. When I was in medical school, I was taught about the vascular system that I should compare it with a water tubing in a house. Well, the water tubing in the house is made of copper. If my arteries were made of copper, I couldn't move. So there must be a difference. The major functional difference that there is, if you think of it, at a time when everybody needs water, this is compensated by the water supply by increasing the pressure in the system. In a fixed tube made of copper, you can only increase the water flow by increasing the pressure in the system. The body does it more efficiently. The body has a flexible tubing system. The body has an artery system that is made up of muscle cells, and these muscle cells can constrict and relax, cause vasoconstriction, vasodilatation, depending on how much blood is needed in a specific organ. You see it here in these ultrasound graphs that an artery, and this is a cross-section, a longitudinal cross-section through an artery, at rest on the left side and after exercise on the right side, you can easily see that the artery is getting bigger, letting more blood flow to the muscle where it's needed. And when we do that on young people and we do it on elderly people, we can show that with age, this ability to vasodilate is reduced. Arteries are getting stiffer. You can measure that by different kinds of methods. You can measure that by doing pulse wave analysis, measuring the central aortic systolic pressure CASP, which is the most convenient way. We didn't have that method at that time. We used this ultrasound method, which gave us the first data to this. But anyway, these tests are functional tests with which you can identify someone who is on the track for heart disease at a very early stage, when no radiograph, no angiography, whatever you take, no exercise ECG can show you anything. That's where you want to pick up the people, where you want to start treatment to prevent the disease. This is another example. It's a coronary angiograph, like cardiologists do it in a cath lab. And on the lower left, you see a left coronary artery with a small side branch at rest conditions. What they did in this study was infuse a pharmacological substance that causes the artery to release NO. Something that happens when you do this is the arteries dilate. Look at the pictures, you can see it. After the acetylcholine, which is the name of the drug, you can see the arteries are bigger. Can you see it? The arteries are bigger. Now look at this individual. The same procedure. On the upper left, resting conditions. On the upper right, treatment with the pharmaceutical drug acetylcholine, and you can see these arteries constrict. They both had coronary artery disease. They both came to the cath lab. They both had their coronary artery disease treatment, and still they were not the same. The person at the bottom has a better prognosis than the person at the top. And this has been proven by prospective controlled studies, that when you are someone whose arteries constrict because there is no NO in this situation, you're worse off in terms of prognosis than when you're someone whose arteries dilate. Lack of NO is a poor prognostic marker. The problem is we can't bring everybody to the cath lab. We can't do all these pharmaceutical tests in the cath lab because it's time-consuming, costly. It has a certain risk in it because you have to have this arterial puncture and all these catheters and so on. No one will pay for that on a population basis, so we need easier tests. And this molecule, which blocks NO formation from arginine, is called ADMA. The chemical name is asymmetric dimethylarginine. It's so complicated that I took several weeks to get that over my lips fluently. You need not try that. ADMA is okay because it's well known as ADMA now. ADMA is an endogenous molecule. Everybody of you has it in the blood, in the cells, in the tissue, everywhere. It's a natural occurring substance just like arginine. It does the opposite. Arginine promotes NO synthesis, ADMA blocks it. And as I said, there are people in the room here, we don't know who that is. I mean, we've tested a few of you, and we know a few individuals who are affected, but not all, who have high ADMA. So this high ADMA will more or less completely block the NO synthetic pathway, reduce the NO-dependent vasodilatation, make the arteries stiff, and with this, set the stage for atherosclerosis to start. We have no means to lower ADMA. There's no drug out there, like when you have high cholesterol, you can lower it with a cholesterol-lowering drug. Well, it may have side effects, but anyway, we have no drugs at all that can lower ADMA. What we can do, as it is competition, the ADMA displaces the arginine from the enzyme. Why not increase arginine and displace the ADMA again? And we thought years back, that this may be the mechanism by which our rabbit was saved from atherosclerosis when we treated it with L-arginine. The NO will increase, the vasodilatation, the reduced platelet aggregation, inflammation, everything is normalized, is brought back to normal again. And I can show you real scientific data proving that. This is the first publication by people from Salvador Moncada's group. Salvador Moncada is a very prominent researcher in the NO field. He has been one of the pioneers of nitric oxide. He has had bad luck then because he was not awarded the Nobel Prize, but Lou Ignarro won it. But it was a tough competition at that time. I know him well. I also know the first author, Patrick Vallance, who has now moved to pharmaceutical industry, but has been working at the University College London for years. We've been good colleagues. What these people showed was that everybody of us has ADMA in our blood, in the urine, in tissue fluids, and so on. What they then did was they extracted this ADMA from the urine at that time, purified it, and infused it into the forearm. And that's the graph you can see there. It shows the blood flow in the forearm, which is at a level of about 100% at the beginning, normalized to 100%, and then they start the ADMA infusion. You see it drops by almost 40%. The ADMA blocks nitric oxide, it blocks vasodilatation, it constricts the artery, and that's why blood flow is reduced. The same happens in a person who has a high ADMA level by himself or herself. So, if we say nitric oxide is an anti-atherogenic molecule, we can by this right say that ADMA is the opposite. And there's one peculiar thing about NO, because this NO in different tissues is being formed by 3 different types of nitric oxide synthase. And there has been a more than 10-year-old debate on which of these 3 enzymes is the most important one. So what people like me in such a debate do is we go to the mouse model and we knock out the gene, and look what happens to the mice that don't have the gene. So people knocked out one of the NO synthases and looked at the survival of these mice, didn't see much difference. Then they knocked out the second one, the third one, didn't see much difference. Then they crossbred them so that 2 of 3 were knocked out. They didn't see very much of a difference. Finally, they had a mouse strain where all 3 were knocked out. And then, that's the red curve, they saw these mice are dying. Nitric oxide, lack of nitric oxide is something that is not suitable for survival. But you have 3 enzymes, so it's hard to knock them out. ADMA is a substance that similarly blocks all 3 enzymes. When you have high ADMA, it doesn't matter that you have 3 enzymes because they are all blocked. And that's why we started to say ADMA is a pro-atherogenic molecule. Everything that NO does good, ADMA does bad. This is from a study I did at Stanford in John Cook's lab. We had the opportunity to study a group of young, healthy adults who had a genetic type of hypercholesterolemia and who came to the outpatient clinic every 6 months for a control. We took some blood and we measured the ADMA. You see here every black dot is one individual. You can easily see that those with a high cholesterol did have a high ADMA level as compared to a group of healthy subjects with low cholesterol. And again, when ADMA is infused into human beings, blood flow is reduced, peripheral vascular resistance is dramatically increased, blood pressure is increased, and we see a compensatory change in cardiac output for those who are medical professionals and know that these systems interact with each other in a compensatory way. There's one study from the group in London and one from our group in Hanover at the time when I had already left. The colleagues did that study very nicely, showing that infusion of ADMA to levels like we see it in patients with kidney disease, for example, causes these dramatic changes in hemodynamics. In the mice, again, we can lower ADMA because we can take the gene of an enzyme that clears ADMA and we can bring it into the mouse, overexpress the enzyme, which is called DDAH, and see what happens. And if you look here, let me show it to you like this. This is ADMA level in a healthy mouse, 1.6. This is in the genetically modified mouse, 50% lower ADMA. What does that cause? It causes higher nitric oxide production. The black bar is almost twice as high than the one in the white strain of mice. They make more NO, and their blood pressure is lower. Their peripheral vascular resistance is lower. This is an effective means of regulating systemic hemodynamics. Very important. Because this explains what we do when we measure ADMA in a group of people. The very first study in which I did this is shown here. It was a group of patients with kidney disease undergoing hemodialysis. It is well known that patients on hemodialysis have a poor prognosis. They have a poor prognosis because they die of heart attack much quicker than the general population. What nephrologists don't know yet is why they have these high rates of heart attack. Their cholesterol is a little higher than in the general population. Their blood pressure usually is lower than in the general population, and many other risk factors that they may or may not have do not explain this. We found that patients with end-stage renal disease have sky-high ADMA levels. When we divided the group into 3 subgroups, depending on the absolute level of the ADMA, and we then followed this group for a couple of years and just recorded who died and who did not, we found that the group with the highest ADMA had the highest death toll to pay, and the group with the lowest ADMA was the best off. That caused us to say that ADMA is a prognostic factor in patients with renal disease. I could keep on like this until 10 p.m. tonight, and at that time, at the latest, I could anticipate that blood flow to your brain is almost zero, so I will not do that. I will summarize it here. You see 24 studies here that have all looked at ADMA, asking whether ADMA is a prognostic factor in a specific population of patients. And when you look through the list, you see patients with renal disease, patients with coronary heart disease, diabetic patients, patients with heart failure, peripheral arterial disease, look through the list, whatever. Any cardiovascular disease entity that you could think of is here, and in every of these categories, ADMA is a factor signifying increased mortality. What if we go through Main Street, Spokane, and just by random pick people, or here in the room, pick you, get your ADMA, and ask ourselves, does this signify anything? This slide doesn't give you the answer, so we moved on. What you can show also in this study is when you do something like the Framingham risk score. The Framingham risk score shows you who is at risk. And if you take those who have a high risk according to the Framingham risk score and compare them to those with a low Framingham risk score, you see the same difference like this. But if in that group that has a low Framingham risk score, you subdivide them further by ADMA, you can show that those people, those women I must say, with a low Framingham risk score who have high ADMA end up with the same mortality rate like those who had a high Framingham risk score from the beginning. So this measurement, this ADMA, adds value to diagnostics. And Framingham risk score is a summary of blood pressure, family history, cholesterol, male gender, smoking history. So very well-known traditional risk factors. ADMA adds some value to it, adds significance. The problem with all these risk scores, and Framingham is the US risk score, we do have German ones, every country now has their own risk score, which is fine because populations are slightly different, but anyway, they all are the same. Because whatever you do, whatever risk someone has, cholesterol-based, blood pressure-based, heart failure-based, diabetes-based, it all ends up with endothelial dysfunction, with a lack of NO, and this is mirrored by a high ADMA. So it's kind of an integrative measure, bringing all these different risk aspects together. We did a sub-analysis in the Framingham offspring study, coming very close to the Framingham risk score with that. You probably are aware of the Framingham heart study, a study that started in the 1950s in the little town of Framingham near Boston, and was the study, the best known study in cardiology, I can say, the first study ever that proved that cholesterol is a risk factor. We didn't know that before the Framingham study. It showed that high blood pressure is a risk factor. We didn't know that before the Framingham study. This was a pioneering work. Well, the participants in the Framingham heart study have become older since the 1950s, obviously. So the investigators there started a second study in which they included everybody whose mother or father or both had been part of the original Framingham study, and they called it the Framingham offspring study. What we can show, and what was a real groundbreaking result, was that in this study, which is population-based, representative for the American population, at least for the New England states, I must say, those who have a high ADMA are at high risk of mortality if you follow them up for 10 years. Those who have a low ADMA are at low risk. The mean ADMA in that study was 0.55. You can see it represented here. We did this as a kind of 0 point. Everybody above 0.55 had a higher risk of dying. Everybody below that had a lower risk of dying. And consider someone who had a level of 0.8. This graph shows that in someone with an ADMA of 0.8, the risk of mortality is increased by 50% during 10 years, which is dramatic, which is as much as someone whose blood pressure is 5 millimeters mercury higher than someone else's. And everybody agrees blood pressure is a significant measurement. ADMA is too. We then did some subgroup analysis to understand this ADMA better. And we identified a reference population within these 3,300 participants who were really free of every disease. Those were the healthy core of this study. You see the white bar here shows that they had a mean ADMA even below 0.55, somewhere in the range of 0.52. And you see that, as I said before, whatever risk marker you take, smoking, cardiovascular disease, hypertensive, obese, diabetic, these groups have significantly elevated ADMA. This is the distribution of ADMA in this population. And you see that at the level of 0.75, there's a threshold. This is the upper range of the normal range. Everything above 0.75 is considered unhealthy, where the investigators looked at patients with coronary disease, peripheral disease, heart failure, and so on, where the mean ADMA usually was somewhere between 0.7 and 0.8. Exactly mirroring what we see here in the healthy population. This is experimental evidence again. I have talked to you about the mice in which we overexpress the enzyme that clears ADMA, so these mice that have 50% lower ADMA levels. We did something similar with these mice like we did before with rabbits. We induced atherosclerosis in these mice. And you see here two examples under the heading control, which is not really control, which is a mouse strain that is prone to develop atherosclerosis. And you see everything that is reddish here is atherosclerotic plaque. On the other side, you see this overexpression of the DDAH1 enzyme that clears ADMA, and quite clearly these mice have less atherosclerosis. So our research that's currently going on trying to identify drugs which may lower ADMA is something that may be fruitful if we succeed to find something with a little side effect, but for the time being, the same can be done with L-arginine. This is shown in this graph, which is a bit complicated. It looks like a US-American city. You see on the one axis, and I'll show it with a pointer, on this axis we go from low to high ADMA. So the white bar here, these are people with low ADMA, and back the dark bars are people with high ADMA. The height of the bars tells you how high the risk of dying is. And of course, those with high ADMA have a higher risk of mortality than those with low ADMA. That's what I'm talking about all the time. What is important here, and what is another aspect of this message, is that the other axis here in the front goes from high arginine to low arginine. And you see when in every row you go from right to left, the bars are increasing too, meaning that individuals with low arginine also have high mortality. And quite obviously, the skyscrapers are in the back left corner. That is the individuals with high ADMA and low arginine. And in the front to the right, you see those with low ADMA and high arginine. They are well off. This is really one central slide for me, one central message in my scientific understanding of this whole field. We have a molecule that is a prognostic marker for cardiovascular disease and death, that's ADMA, which is central to the pathophysiology. And John Cook has recently had a review article with the heading ADMA, the Übermarker, question mark, meaning that ADMA may be a marker that integrates high cholesterol, high CRP, high homocysteine, all these new and fancy risk markers into one measurement. But this alone only tells us half the truth, because ADMA without arginine signifies nothing. What we need is the ratio of arginine over ADMA. And when you have a chance to see that circulation paper, the data is in there, we published it in Circulation. The ratio of arginine over ADMA is an independent risk marker in its own right. Those with a low risk had an arginine ADMA ratio of about 100. Those with the highest risk had an arginine over ADMA ratio of about 30. I could summarize it in this way. Low ADMA only means low risk when arginine is high. When an individual with a low ADMA has low arginine at the same time, that doesn't help you at all. Don't worry if you don't understand everything today. It took me 13 years. When I had finally understood this, I thought, how can we measure this all? We had these measurement technologies in my lab to measure ADMA by enzyme immunoassay, by high-performance liquid chromatography, by liquid chromatography, mass spectrometry, and other technologies. The wording is as difficult as the technology itself. It's costly, it's time-consuming, it needs a specialized lab. We have it, but not many have it. So this is not working. And we then devised a technology to have an easy test to measure not only ADMA but also arginine everywhere, in every place in the world. And this is what we call ADMA card in Germany, and I'll show you the American version of it that Mark Rosales devised a little later. It's a dry blood test. It's a field card where you put a drop of blood, 6 drops of blood, on, let it dry, put it into an envelope, send it to the lab, and you get your result on ADMA and on arginine. And we can calculate the arginine-ADMA ratio from that and have a prognostic answer. This is the American version that Mark Rosales devised. It's called ADMA Now, and it's a wonderful technology that is brought to everybody now. This science is at your hands with this. I'm very proud of this because, well, I spent 20 years of my life in this science. I could have stayed in the laboratory thinking about science and thinking about how this all belongs together, but as I said in the beginning, I'm a medical doctor. I want to improve medical treatment and medical diagnosis. So we have to bring this out into your hands to get you the understanding what this is all about. Have you used this? We have invested tons of money for the development of these assays. I've spent 20 years of my life on that. I've had grants of several $million, if we convert it to dollars, that we've invested into our lab work to make all these big studies possible. We have big studies now. So this is solid science. This is not some fancy stuff that has no scientific basis. This is real science brought to you. I showed to you, and I repeat here, this slide from the rabbit study, because I think this is very important information. This is the only treatment so far we have to antagonize high ADMA level. There's nothing else. And we don't only do it in rabbits, it works in human beings as well. So don't worry and say, I'm not a rabbit, what is he talking about? In Stanford, in the study where we had these young people with high cholesterol analyzed and found they have high ADMA, you may remember that we did a test for the elasticity of the arterial system, which is called flow-induced vasodilatation. You see on the right side again the control group with a low cholesterol, with a low ADMA, and you see the shaded area is the range of measurements we found in that group. That's the normal range. That's where everybody should be. Those 25, 30-year-old persons with high cholesterol, nothing else, no disease, clinically healthy, were way below that, as you see. A couple of them agreed to participate in a study where we gave them one single dose of arginine and repeated the vascular measurement. And this one single dose of arginine increased their vascular function into the normal range. Why is that? Because they were young. The functional disturbance in the arterial system that they had was reversible. They did not have calcified plaque that no one can do anything about except by cabbage or stent. They had functional disease that is reversible by nature. And we gave them arginine and we reversed it. Later on in my career, I worked in a clinic where we treated patients with peripheral arterial disease. And I thought something that worked so nicely in these healthy subjects should be tested in those patients who cannot walk because they have peripheral arterial disease. You see here the result of another study where, again, we gave a single dose of L-arginine and measured the blood flow to the leg, to the diseased leg in these patients for 150 minutes after the infusion of L-arginine. That was infusion at that stage. And you see that L-arginine, as compared to the placebo group, dramatically improved blood flow into the leg that was diseased and that was lacking blood. We then went on and generated these nice colored pictures. I like them a lot because they are so colorful, but they are also important from a scientific view. What you see here is the left and right calf of a patient with peripheral arterial disease. What the colors indicate is the rate of blood flow in the muscle. And you can see by the scale on the right side that dark blue, blue, green is bad perfusion. Yellow, orange, red would be good perfusion. You almost can't see any yellow, notwithstanding orange or red, you can't see anything. So it's a proof that blood flow in the muscle is bad in these patients. That's why it hurts. Well, we kept them lying there and gave them arginine and repeated the test. And you see, there is it. There the blood flow comes to the skeletal muscle of the lower extremity. These people, if that holds on for a longer time, can walk again. But again, that was single dosage, short-term effect, but it kept us confident that a long-term study might work out. And I was still working in that clinic, and we had people lying on my ward asking me, what can we do? What we measured here was the pain-free walking distance. We put them on a walking machine and measured the distance they could walk on the machine until they said, oh, I have to stop, it hurts. But the interesting thing was that the third group that was treated with arginine in the same way, 2 dosages per day for 3 weeks. I can proudly say arginine, it's not a drug. It's not approved in Germany. No one even tried to get approval for that. It's a dietary supplement. But still, in those patients who have a high ADMA level, whose NO synthesis system is impaired by this, it works. It normalizes NO formation. And by this, it increases flexibility and increases the blood flow around the stenosis in the femoral artery. And that's why these people can walk again. If we consider cardiovascular disease as a continuous process of deterioration, starting off with some risk factors at a very early stage, and then moving on to asymptomatic vascular dysfunction, coronary heart disease, calcification, acute occlusion and infarction. And for those who survive it, it moves on to heart dysfunction, dilatation, chronic heart failure, and then at some stage, finally, death for sure. And look what studies showed for arginine. It turns out that all studies that have been done show arginine works in the early stages. Most studies show that with overt cardiovascular disease also arginine works. But there is some controversy in the later stages. And this, if you look exactly into the studies, is something that can be easily explained. There are a couple of studies made by non-believers. They took people with a coronary artery stenosis, they gave them arginine and measured in the stenosis whether the stenosis changes. It's calcified. How could it? So it turns out to be a negative study if you look at the stenosis. But the stenosis itself is not important because the body develops bypass arteries and they have to dilate. If you measure there, you see it has a grand effect and you have a positive study. That's why there's lots of controversy. All the studies that looked at symptoms, walking distance, exercise performance in patients with coronary artery disease, all these studies showed improvement. So even this guy, at this late stage that he is in, can be helped. Not with a stenosis that causes this acute heart attack in that situation. But atherosclerosis is a systemic disease. Those who have it in the coronary artery also have it in the carotid artery, in the legs, in the renal artery, wherever. And you have more than one coronary artery, luckily. So if you have one stenosis, there's lots of coronary arteries you can still save. Go out there and do it. And I hope I have convinced you that the sun cream that we should use for the vascular system is L-arginine.